सच का दम भरे, दूसरों की जय से पहले खुद को जय करे। हमको मन की शक्ति देना, मुश्किलें पड़े तो हम पे इतना करम कर, साथ दे तो धर्म का, चले तो धर्म पर, खुद पे हौसला रहे, बदी से ना डरे। दूसरों की जय से पहले खुद को जय करें। हमको मन की शक्ति देना, मन विजय करें। दूसरों की जय से पहले खुद को जय करें। हमको मन की शक्ति देना, हमको मन की शक्ति देना, हमको मन की शक्ति देना।
Namaste, my dear brothers and sisters. The love and blessings of the Mother and Sri Aurobindo to all of you from Sri Aurobindo Ashram, Delhi branch. This popular devotional song, Humko Man Ki Shakti Dena, Man Vijay Kare, is about the conquest of the mind. The mind referring to both the feeling and the thinking part of the mind. And the conquest does not mean rejecting them in favor of something better, but the conquest means transforming them so that they get illumined by something which works at a much higher consciousness than the mind, or rather, of which the mind is a surface manifestation. Our mind is a surface manifestation of our divine essence, the soul, which also has a dynamic component, the psychic being, which participates in day-to-day life by influencing the instruments, the body and the mind. So the conquest means that these instruments, and here in this devotional song, the reference is to the mind as the instrument, both the feeling and the thinking part of the mind, let them be conquered by the divine essence so that they are illumined by the divine essence and they work in light of that, so that the emotions, instead of being volatile as they normally are and the intellect vacillating as it normally is, these normal tendencies, the so-called normal or usual or ordinary tendencies of the mind, are replaced by something higher, something much better. The emotion left is one that of love, and the thoughts in keeping with it, the thoughts of universal love that is unconditional in nature and does not expect anything in return. Now, this is the result of the spiritual path making us realize a sense of oneness with the rest of the creation. And once there is oneness, then the rest of what is said in the devotional song follows. That is not distinguishing one person from the other, not having a sense of partiality when we are dealing with people. That doesn't mean that we lose the sense of right and wrong, but we see even in the one with whom we do not agree or the one whom we do not like, we see in that person also the divine, and therefore we may not agree with the person, we may not like the person, but we can still love the person as a manifestation of the divine. And that is what is meant by not distinguishing or uh, having a sense of partiality when dealing with people. And another important consequence of it, which is mentioned in this song, is forgiveness. Because the inability to forgive or the difficulty that we normally experience in forgiving is once again because we are unable to accept the other person as one of our own, as somebody who is not really very different from us, who is an imperfect manifestation of the divine, the way we are. And that makes us take a more charitable view of the defects or drawbacks that we find in the other person, and therefore becomes easy to forgive. And the other counterpart of it is that it also makes it easier for to apologize when we have done something wrong or when we have hurt somebody. So that's about the devotional song. Today's topic is the respiratory system, and I keep going back to it because that, in fact, is something very fundamental, something towards which all the systems in the body are working. That is keeping us alive by providing the cells of our body the right conditions to work. And the right conditions are that the fluid surrounding these cells should be adequate in terms of food supply, oxygen supply, the right temperature, the right amount of saltiness, and it should not have any accumulation of the waste products that the body generates in the process of living. The very process of living uses up fuel and oxygen and generates waste products like carbon dioxide and ammonia. So these waste products should not accumulate because they would be toxic to the cells. The respiratory system plays an important role in this by uh, replenishing the oxygen that has been used up by different parts of the body and helping us get rid of the carbon dioxide that is being produced as a waste product. And it is for this reason that, in fact, the arrangement in the body is such that all the blood returning from various parts of the body after giving up some of its oxygen and collecting some carbon dioxide uh, is pumped into the lungs by the right ventricle. And after removing some carbon dioxide and adding some oxygen to it, the this blood returns to the left heart, and the left ventricle then pumps this uh, blood, which is now richer in oxygen, poorer in carbon dioxide, to the entire body. So this is something, this cycle we saw while studying the cardiovascular system. Today we shall look at in some detail what happens in the respiratory system. So with this now I'll go to the PowerPoint presentation. Once again, the participants whom I can see and whom I like to see, I have moved you to the left-hand side so that on the right-hand side I can see the slide, and that's why I'm not going to full screen. The YES course and other activities of the YES project are a part of the 150th birth anniversary celebrations of Sri Aurobindo and the 75th anniversary of India's independence. As in the cardiovascular system, here also much of the realistic anatomical pictures in the presentation have been taken from the 10th edition of Tortora and Grabowski's Principles of Anatomy and Physiology. Let me start with this quote from the American physician Oliver Wendell Holmes. The smooth, soft air with pulse-like waves flows murmuring through its hidden caves, whose streams of brightening purple rush, fired with a new and livelier blush, while all their burden of decay the ebbing current steals away, and red with nature's flame they start from the warm fountains of the heart. A poetic description of the function of the respiratory system. The smooth, soft air with pulse-like waves flows murmuring through its hidden caves. So the reference is to the lungs. The air uh, flowing through the lungs, which have been compared to the hidden caves of the body, and rather maybe the hidden caves within the lungs, which where the gas exchange actually takes place. So the air flows in through the lungs, whose streams of brightening purple rush, fired with a new and livelier blush. And the result of this air entering in the lungs, the areas of the lungs where gas exchange takes place, is that the blood flowing in acquires a new and livelier blush. Looks more red because of the oxygen that has been added, while all their burden of decay, all their burden, whose burden? The streams of brightening purple. Purple referring to the blood which had less oxygen and more carbon dioxide. So all their burden of decay, so the carbon dioxide and reduced oxygen levels is a sort of a burden of decay, as is called it. Uh, while all their burden of decay, the ebbing current steals away. So this current of air steals away this burden of decay and fires the blood with a new and livelier blush. And what happens to this blood with a new and livelier blush? The red blood, and red with nature's flame they start from the warm fountains of the heart. So it then it starts as a warm fountain from the left ventricle of the heart to be distributed all over the body. Now, this is a realistic picture of the respiratory tract, and we breathe in through the nose, it goes through the throat, and then down the trachea, and then from there to the lungs. This is the space where the heart fits in. Now, as the air is passing through the nose and the throat, uh, it doesn't enter the lungs as it enters. In the nose, it undergoes warming, humidification, and cleansing. Warming, because generally speaking, the air that we breathe in is colder than the body. The nose inside is at the temperature of the body, that is 37 degrees centigrade, and usually we breathe in air that is at a lower temperature. By staying in the nose, staying because it doesn't have too smooth a passage. Within the nose there are partitions which make the slow down the flow, and it is further slowed down by the wetness inside the nose, the mucus, and perhaps further slowed down also by the hair in the nose. We can all see some of these hairs sometimes coming out of the nostrils. So all this ensures that the air stays a while in the nose, and while it is while there is staying there, it undergoes a little rise in temperature, it becomes a little warmer, it becomes wet, it's humidified, and it becomes cleaner because some dust particles, etc., get trapped here. And then the air passes through the throat and then the trachea, from where then it is distributed through the branches of the trachea, which branch out like the branches of a tree and spread throughout the lungs, till we have the smallest units where the gas exchange actually takes place. Now, the process which started in the nose continues here because these places are also wet, warm, and have a tiny hair, not big hair like the we see here, but tiny little hair at the end of the cells, which we call cilia. Now, these uh, do not act in the same way as traps. The uh, mucus may act as a trap, but then what the cilia do is they keep beating upwards, which means that they make this whatever has been trapped move up with the fluid or liquid mucus in which they have been trapped till it reaches the throat. And then once it reaches the throat, it gets swallowed so that it reaches the stomach. Because all this dirt and filth and muck that might have accumulated here or which has been taken care, trapped here, is much better sent to the stomach where it will do no harm than entering the lungs, which are kept clean. So what enters the lungs is good and clean air. Now one can understand that if one this will happen only if one breathes through the nose. If one breathes through the mouth, what the nose was doing has been uh, cut short. It straight away reaches the throat. Some cleansing will take place, some warming will take place, some humidification will take place. But along with that, what will happen is that if we try to make the throat do the same job which the nose was supposed to do, uh, the germs which may enter here in the throat could lead to a frequent inflammation of the structures here, like the tonsils and the adenoids. And that's why nose breathing is much better than mouth breathing. But then why does a person like to breathe through the mouth at all? Uh, we like to breathe through the mouth because that offers much less resistance than the nose. We saw the nose does offer some resistance, and that's why the air slows down and stays a while here. From the mouth, it can straight away rush to the throat, big passage, nothing to stop it, and it reaches the throat. So it's the path of least resistance. And that's why the children, particularly, have a tendency to breathe through the mouth, and that's what gives them frequent attacks of tonsillitis. Uh, and therefore, what's important is to cultivate in the child the habit of nose breathing. Now, once a child has developed the habit of mouth breathing, uh, it has a tendency not to give that up, like any habit, because habits make us slide down a path, and sliding down is much easier than climbing up. So the child has gone down that path, which is the path of least resistance, breathe through the mouth. Now, it's difficult for the child to now breathe through the nose, particularly when the child is sleeping at night. And therefore, then what is the solution? And the solution is exercises which are designed to uh, make the child habituated to nose breathing and reduce the resistance in the nose, make it easier for the air to pass through the nose. So, what are those exercises like? Simple exercises in which you may say, make the child hold a thick piece of cardboard in the mouth and then make it jump like a bunny or jump like a frog. You'll see some of these things in the next practical class, which will be how to teach yoga to children. So you make the child jump like a frog or like a bunny with the card in the mouth. Holding the card in the mouth means the child has to uh, clench its teeth, keep it firmly in the mouth, and will not be able to open the mouth. So then the child is compelled to breathe through the nose while taking this exercise. So if the child can breathe through the nose while taking exercise, when we breathe faster and more deeply than normally, the child will pick up this habit of breathing through the nose. The resistance there will go down, and that is one of the ways which is tried for doing. So now we understand why nose breathing is better than mouth breathing, because that avoids the throat uh, doing the job of the nose, and which it can't do, and that can lead to frequent infections in the tonsils and adenoids. You might have also seen, particularly in children, that a throat infection also causes pain in the ear. Now, what has the throat got to do with the ear? Naturally, there must be a connection. And there is a connection between the two, which is called the eustachian tube. And if you sit, uh, look at the inside of the nose and the throat area, you find that in the throat area, which is called the pharynx, this little thing written here is the ET opening. This thing, is the ET means eustachian tube, opening of the eustachian tube in the throat. Eustachian tube is also called the auditory tube or the pharyngotympanic tube, but the common name is eustachian tube, and that somehow continues to stick. All the others are more meaningful. So this is the opening of the eustachian tube. Now, from here, does it go to the ear? And you can see that here. This is that same tube going right up to the middle ear. The ear has three parts, which we'll see more when we come to the study of the ear. But so this is the part that we see, the external ear, and through the ear canal, it leads to the tympanic membrane. And on this side is the inner ear, the part that is concerned with the hearing, transmitting the vibrations which take place as a result of the sound that we hear, transmitting that in the form of electrical impulses to the brain. Now, this is the middle ear. The function of the middle ear is that it magnifies the movements of the tympanic membrane. The tympanic membrane vibrates as a result of the sound waves, But then that is not enough to really lead to the impulses that are generated in the inner ear. So these get magnified. So in the middle ear, we have a lever system that magnifies the uh, force with which the force that is transmitted to the inner ear. But then the result is that this becomes a closed cavity, closed on this side because of the eardrum or the tympanic membrane, closed on this side because of the inner ear. So this is a closed cavity. However, there is a little opening available, and that is on this side, and that goes all the way up to the throat. And the result is that if there is a throat infection, it can travel up here and cause an infection here. And that is what leads to pain in the ear. And if this happens very frequently, then uh, it can also form pus as elsewhere in the body. Wherever there's a frequent infection, there can be formation of pus. And because of that infection, this tube may be blocked. And then in this closed cavity, as the pus accumulates, the pressure grows, this drum, the eardrum, can burst because this is the only place left from where that then pus can ooze out. And that's what leads to a perforation or a hole in the tympanic membrane and a gradual sort of discharge of the pus from here. Uh, not uh, very common, but all the same, not too uncommon, particularly in the children in the underprivileged sections of the society where the hygiene is poor, the attention to the throat infections is not as much as it should be, and the result is that the throat infections are not treated and they lead to this type of a problem, which is called the chronic suppurative otitis media. Chronic because it's a chronic disease, suppurative associated with formation of pus, otitis, anything itis means inflammation. Otitis means the inflammation of this part of the ear, and media because the middle ear. So otitis media is suppurative disease of the middle ear, which is chronic, and that can show up as a perforation here, which leads to discharge of pus. So these are the problems that it can lead to, and that is why one may not always go to the that level, but some pain in the ear associated with the throat infection is a common experience. Each one of us has had it sometime or the other. And the children have it more often than the adults because of uh, this tube being relatively straight in children, straight from the ear up to the throat, which is almost at the level of the nose. Whereas in adults, it's a little sloping like this because the shape of the face changes as we grow up. And because of this slope, in the case of the adults, it has to climb up to the middle ear, which is more difficult than to flow straight from the throat to the middle ear. So that's why more common in children. But then one may say that if the tube can cause so much of a problem, then why have the eustachian tube there at all? Why has nature put this connection there? The ear could have done its job just here, and the throat could have done its job just breathe and swallow. Why do we have this tube connecting the throat with the ear? There's a very important reason why it is so, because we saw that otherwise this is a closed cavity, and any closed cavity will also have some air in it. And we are not, and on this side also there is air. The external ear is exposed to the air. Now this pressure can change. Suppose one is in an aeroplane, or you go to the high altitude where the atmospheric pressure is lower. Now this pressure will become low, but because this is a closed cavity, it will continue to have the same pressure. Suppose this was earlier at the atmospheric pressure at the ground level, the sea level, before we started flying in the air. This has that pressure. So this pressure is higher than this pressure. What will happen is that this will make it bulge. And this bulging will at least cause pain. Occasionally, it could cause a rupture. So that's why. And the other way around is also possible. Suppose the air here was at the low pressure, and then the person goes for sea diving where the pressure is higher. Then the pressure here increases, and that will push the eardrum in, and the air here will get squeezed, squeezing the structures here, which will then affect their function as a lever. So which means that the pressure here should be the same as the atmospheric pressure. Whereas for its function, it has to be a closed cavity. So then what helps is this tube, which connects it to the throat, which is at the same pressure as the surrounding air. So the pressure in the throat falls when we are at high altitude or on the aeroplane. So that is why the throat is at the atmospheric pressure, but same time, this opening here is normally closed. It's not open all the time, which means that for all practical purposes, this remains a closed cavity, but there is a possibility of this opening. And when does it open? To equalize, keep equalizing the pressure momentarily for a split second every time we swallow. That is when the pressure keeps getting equalized. And that is why you must have seen that now it's not so common, but earlier they always used to distribute some lozenges in the aircrafts so that you could keep them in the mouth so that you'll have more saliva, you'll swallow more frequently, so that when you go up in uh, when the aeroplane takes off and you are quickly at a higher altitude where the pressure is lower, in spite of the plane being pressurized, the pressure is considerably lower than outside. When that happens, by swallowing, you will be able to have the same pressure in the middle ear as in the throat, which is at the pressure or the air around us. And therefore, if a person has a blocked eustachian tube, the person is likely to feel pain and may also have a more serious injury of the middle ear while flying. So the eustachian tube has a function, uh, and apart from this, it's also important for the middle ear to be in good shape so that it's able to transmit faithfully the vibrations of the tympanic membrane to the inner ear. So nothing is redundant in the body. The master craftsman has taken care of every minor detail. Now, this is another view of the lungs. The larynx is the voice box because that's where the sound is produced. And this is the trachea. Now, the main tube that then divides into two bronchi to go to the lungs. Now, this trachea, you can see, has a ring-like structures all around. These tough rings have between them softer muscle tissue. And anybody can feel that in the throat. If you feel your own throat, you will be able to feel that this is the larynx, the voice box, and below that is the trachea, which has these rings alternating with a softer material. Why are these rings there? So that the trachea doesn't collapse. If it was all soft, it would collapse. But then why not all hard? Why have these soft areas in between so that the neck remains flexible? So this is how the neck remains flexible and at the same time it is rigid enough not to collapse. The same principle we follow in many of the tubes which have corrugated tubing, rubber tubing. We follow that where we require both these things together. Or for that matter, in table lamps, you would have seen that you can bend the table lamp because of this type of a tube, which remains rigid, through which the wire can pass. It remains, maintains its shape. At the same time, it is flexible. You can bend it. And here you can see the division into branches, like the branches of a tree, the trachea dividing. Yeah. And finally, after dividing repeatedly, we reach structures which are too small to be seen in this type of a picture, but we can diagrammatically show them like this, that at the final level, we have these air sacs or the alveoli, and uh, in close contact with the alveoli are the fine blood vessels, the capillaries of the lungs, and the blood enters here, which has less oxygen, more carbon dioxide, and as it flows out, it has less carbon dioxide and more oxygen. We'll come to this gas transport a little more in detail in the next class. Today, we'll concentrate on the mechanics of breathing. How are we able to breathe at all? We are able to breathe because air has a tendency to flow from a high pressure area to a low pressure area. And to understand that, let's see this picture. Now here you have two balloons which are connected by a tube, and there is an arrangement here by which we can close this opening so that the two will not communicate with each other. But while they are communicating, the air pressure in this balloon is the same as the air pressure in the other balloon. Now we close this clamp and this has been blocked. And after doing that, suppose we squeeze one of the balloons. So this person is squeezing this balloon. Now you can imagine that when you squeeze it, it feels more tough, which means that the pressure here has gone up. The pressure here is now, because of the squeezing, is higher than in this. Now we maintain that squeezing action and then release this clamp. What will happen is air will rush from here to here, from the squeezed balloon to the other one, because the pressure here is higher than over here. So air has a tendency to flow from high pressure to low pressure, which means that if the air has to flow into the lungs from the outside air, the pressure in the lungs should fall below the atmospheric pressure. Right? And that is what happens. Now, how can you decrease the pressure in the lungs? One way to do it is to expand, because if you fill the same amount of air in a larger space, the pressure falls. So the amount of air in the lungs remaining the same, if you make them expand, the pressure in the lungs will fall, and therefore the air will rush from the outer atmosphere into the lungs. Okay. Now, how do the lungs expand? The lungs expand when the chest expands, and the chest can expand in three directions: from above downwards, as a result of the movement of the diaphragm. Diaphragm is the partition that separates the chest from the abdomen. So when that goes down, naturally the chest has the length from the top to the bottom of the chest increases. So from above downwards due to the movement of the diaphragm. Sideways due to the movement of the ribs. So the ribs move, so the chest expands sideways. And from the front to the back due to the movement of the sternum or the breastbone. Here is the breastbone. And when that moves forwards, the dimensions increase from front to the back. Now let's see these movements a little better, particularly these two. The diaphragmatic movement is relatively easy to understand. Let's see the other two movements. Now here, this is the diaphragm, and that is easy to understand, that you have this concavity, and if this diaphragm contracts, which means this muscle becomes shorter, when it will become shorter, it will also become less concave. And the result will be that from top to bottom, the length will increase. Earlier it was this much. Now you have this additional length added. So from top to bottom, now it has increased. So this is now longer than this. So the diaphragm has gone down as a result of the contraction of the diaphragm. Now let's see the movement of the ribs. The ribs are curved in such a way that they are comparable to the handle of a bucket. So if you lift up the handle of a bucket like this, earlier the handle was extending up to this level, now the handle is extending up to this, so this much has been added. So that's how the chest expands sideways as a result of the movement of the ribs. And because of this type of a image that one can have, it has been also called the bucket handle movement. Now let's see the movement of the breastbone, the sternum, that is this bone. For that, let's look at it from the side. So now this is that breastbone. If you look at the chest from the side, this has moved forwards. So if this moves forwards, naturally this much has been added to the length from the back to the front. And this is comparable to the movement of the handle of a pump. So as the handle goes up, the way the sternum goes up and forwards, you find that this length, this distance has now increased as compared to this distance. So this is the pump handle movement. So that's how through these three movements, the movement of the diaphragm downwards, and the movement of the ribs, and the movement of the sternum, the chest expands in all the three directions. So the chest expanding from above downwards due to the movement of the diaphragm is what we call abdominal breathing. And expanding sideways and from the front to the back is what is chest breathing. Now, here all three have been summed up in just one line. The chest expands due to the movement of the diaphragm, the ribs, and or the sternum. Now, which of the three is most efficient? We don't need all these to move all the time, because we need only at resting level, we have less oxygen requirements, a little bit of movement with one of these three, or rather at least one of these two, the diaphragm or the ribs. The sternum doesn't contribute that much. These two will be enough. So which of the three is most efficient? The most efficient is the movement of the diaphragm, because you can visualize also it's such a big muscle, and that going down, increasing the dimensions from above down, will give us a greater change in the dimensions of the chest with relatively less muscular effort. So less effort, more output in terms of increase in the space in the chest is what efficiency is about. Greater output compared to the input. The input is the effort put in by the muscles. Here the effort is put in by the diaphragm. So relatively less effort by the diaphragm will increase the dimension of the chest from above down, or the chest as a whole, more than that little bit of addition that the movement of the ribs or the sternum can make. They'll have only a limited impact on the space that increases, and the muscular effort will be considerably more, because so much of muscles between those little muscles between the ribs will have to contract. So out of the three, the diaphragm gives us the most efficient movement. But which of the three do we normally use? Most of us are chest breathers rather than diaphragmatic breathers. We breathe through the chest rather than use the diaphragm. So we have chest breathing rather than abdominal breathing. And why does that happen? Because our dresses, by and large, are such that they constrict the waist. And therefore, it's difficult for the abdomen to move out. In diaphragmatic movement, the abdomen moves out. And why that happens, we shall see in a moment. So because the abdomen cannot move out, we tend to use the chest rather than the abdomen. On the other hand, if you see a baby uh, who doesn't bother about what it is wearing, and it is lying, and you can see its abdomen flapping up and down while it is breathing. So we are born with abdominal breathing, but then as we grow up and start using the dresses which constrict the waist, we turn into chest breathers. And the training in army and NCC and so on doesn't really help, because there, when the instructor gives the instructions, he says, chest out, tummy in. Which means they breathe the chest, keep the tummy in all the time, which means don't let the tummy move. So you're doing a little bit of breathing using the chest. Now, so this person is in Shavasana, and the instructions given are, as you breathe in, the abdomen moves out. As you breathe out, the abdomen moves in. Now, what type of breathing is she having? Is she having diaphragmatic or abdominal breathing? When we give these instructions, the person is actually having abdominal breathing. So in Shavasana, the breathing is diaphragmatic or abdominal. But then in abdominal breathing, why does the abdomen go out while breathing in? One of the participants asked me actually that in abdominal breathing, does the air go into the abdomen? The air doesn't go into the abdomen. The air still has to go to the lungs. Why the abdomen moves out while breathing in is because as the diaphragm goes down, it presses on the stomach and the intestines. And because it presses on the stomach and the intestines bulge out. So it is the stomach and the intestines bulging out because of the diaphragm going down that the abdomen goes out while we breathe in. The air still goes into the lungs. So the abdomen goes out because the diaphragm presses on the abdominal organs. Is abdominal breathing only for Shavasana? Or should we have it the rest of the time also? Because the rest of the time we are breathing through the chest, as I said, most of us are chest breathers. No, it is not only for Shavasana. Since abdominal breathing is more efficient, it should become a habit. It should spill over from the Shavasana to the rest of the day. However, Shavasana is a good way of training ourselves, or rather retraining ourselves, to breathe, to have abdominal breathing. Why? Because it's easiest to have abdominal breathing in the lying down posture, a little more difficult if you are sitting up, and still more difficult when you're standing. So it's most difficult to have abdominal breathing in the standing posture, and the easiest in the lying down posture. And therefore, to practice abdominal breathing in Shavasana is a good way of retraining ourselves to have abdominal breathing. So it's not only for Shavasana, but Shavasana is an easy way of learning abdominal breathing because it's the easiest in that posture. But then some people also say when they are doing Shavasana that my abdomen goes in while breathing and it doesn't go out. So in some people, why does the abdomen go in while breathing in? That happens because they are chest breathers, as most of us are. And as the chest moves, they continue to have chest breathing even in Shavasana. So if one has chest breathing also during Shavasana, what happens is the diaphragm is not moving, but the chest is expanding. The dimensions of the chest are increasing from sideways and from front to back. And when that happens, the pressure here has fallen. The pressure in the abdomen has remained the same. The diaphragm is acting like a passive partition, And the result is that as a result of fall in the pressure in the chest, because of the movement of the ribs and the sternum, the diaphragm gets sucked up. Because the pressure in the abdomen remains the same, that is higher. In the pressure in the chest has fallen. So from high pressure to low pressure, there will be a movement. The higher pressure will push the structures towards the low pressure area. And that partition is the diaphragm. So it will push the diaphragm up, which means that the diaphragm will get sucked further deeper into the chest. And when that happens, naturally, if the diaphragm moves up, the abdomen goes in because now the stomach and intestines have more space. So that's why in some people the abdomen might go out because these people. So in some people, why does the abdomen go in while breathing in during shavasana? Because they go in for chest breathing. That is what their habit is. They are chest breathers, and the result is that the diaphragm gets sucked upwards. Now we come to a little study of the lung volumes and capacities. There's a technical nomenclature for how much air we breathe normally and how much we can breathe in if we make an extra effort. And if you don't follow all the terminology properly, it's okay. But it'll give you some idea of these terms if you see them in a report in which your lung functions have been tested. Normally, we breathe in about half a liter of air and breathe out the same volume. And that is what is called the tidal volume. So the tidal volume is the normal amount of air that we breathe in and out while we are at rest. However, if we make an extra effort, we can breathe in a lot more air, which means that this much we were breathing in already. The remaining air, which we can breathe in only with maximal effort, is the reserve that was held. Reserve for breathing in more air. And that's called the inspiratory reserve volume. And this inspiratory reserve volume, together with the tidal volume, that is the air, the entire amount of air that we breathe in as a result of maximum effort, starting with the normal breathing out. So this is the level of normal breathing out. From here till the maximum that we can breathe in is the inspiratory capacity. So this is our capacity, whereas this is out of this capacity, this much is held in reserve. So this is the inspiratory reserve volume and this is the inspiratory capacity. And you can see the inspiratory reserve volume is much greater than the tidal volume. So a lot of it is held in reserve. Physiological reserve is something which we all have, which comes in handy in situations like exercise and also in disease because we keep encroaching on the reserve rather than get symptoms. Now, just as we have a reserve for breathing in, we also have a reserve for breathing out. So this is how much we breathe out normally. But if a person makes maximal effort to breathe out, the person can breathe out this much more. So you can see that the expiratory reserve is not as much as the inspiratory reserve, but at the same time, reserve is there. No matter how much effort we make to breathe out, it's not that the lungs become completely empty of air. So some air is still left behind in the lungs. That is what we call the residual volume. So this is the expiratory reserve volume, the volume that is not normally breathed out, but can be breathed out with maximal effort. And this is the air that still will remain even after maximal respiratory effort. This is the residual volume. Now, normally, we don't breathe out this much. We breathe out only up to this level. Then how much is the amount of air left in the lungs? This much, which means this residual volume and also the expiratory reserve, all this is still in the lungs. So this is called the functional residual capacity. That means in normal function, on ordinary breathing at rest, we hold this much of the air at the end of breathing out. This much air is still in the lungs. So this much residue is still in the lungs. We call it the functional residual capacity. Now you go one step further. Suppose we start with a normal breathing in, breathe in as much as we can, then breathe out as much as we can. So this amount that is breathed out, starting from a position of maximum inspiration, and after making maximum effort to breathe out, this is called the vital capacity. doesn't mean higher the vital capacity, the stronger the vital of the person. But this is called the vital capacity. So this is the vital capacity. The maximum amount of air that a person can breathe out starting from the position of maximum inspiration. And very often in pulmonary function tests, other volumes are not necessarily reported. What is reported is the vital capacity. So you know what vital capacity is and why you were asked while going through that test, breathe in as much as you can and then breathe out as much as you can. Why that was asked? Because that is the time when your vital capacity could be recorded. Now, on this is the volume on this axis. On this axis is the time. Now, you can see that this time that you take to breathe in, breathe out is being converted into distance. So the distance from here to here or here to here or here to here, this distance is a reflection of the time taken to breathe in or breathe out. And how that happens is, one of the ways it happens is that the surface on which this is being recorded is moving. So because it moves, your breathing in and out does not get recorded as a straight line because the paper has moved a bit. By the time you are breathing out, it gets recorded as a curve. So here time is being converted into distance. Why I'm saying this is because you can make the paper move faster. If the paper moves faster, this distance will increase. And that is what is done in one of the tests we'll come to. But before that, this entire amount of air in the lungs, that is starting from the maximum inspiration up to this level, which includes the residual volume, is called the total lung capacity, and it's about 5 liters. So the total lung capacity is about 5 liters. Now we'll see how by moving the paper faster, the curve can change and why sometimes we do that. We do that to measure what is called the timed vital capacity. Here the paper is moving faster. You can see from here, 0 to 20 seconds is this much, but then there's a break here. Now we have expanded in such a way that from 0 to 5 seconds, just 5 seconds is this much. Here 20 seconds was such a short distance. Here 5 seconds has become such a long distance. And these are 3 curves. This is the normal curve, which means that the person has breathed in and breathed out as fast as the person could. And this is the type of curve that we get. And how much is breathed down in 1 second? That is the first second of breathing out, about 80%. So about 80% of air that was breathed in can be breathed out within 1 second. But then there are 2 types of disease conditions in which you get different type of curves. Now here you find that the maximum amount of air is not very different, but the air is breathed out very slowly. So when the air is breathed out very slowly, you find that the curve is like this. And instead of 80%, only 50% or 20% of the air might be breathed in during the first second of breathing out. And the rest is squeezed out slowly over a period of 5 seconds. Here, almost all of it was out in the first second. Here, it takes 5 seconds. Here, it had reached this level. Only this much more had to be breathed out in another 2 seconds. But within the first second, it had reached this level already. So 80% was out in the first second. Here, much less, and the rest is breathed out. Now, when would this happen? You can imagine this would happen if there's an obstruction in the airways. So if there's an airway obstruction, the air does not flow in easily due to whatever reason. If there's an obstruction in the airways, and the typical disease condition where this happens is bronchial asthma, when a person has an increased airway resistance, the airways offer more resistance than normal, then the timed vital capacity is like this, which means that the percentage of air that is breathed out during the first second, that falls. And sometimes in the report you find FEV1. FEV1 stands for forced expiratory volume in 1 second. So using maximum effort, forcing the air to go out, how much could the person breathe out in 1 second? That how much volume the person could breathe out in 1 second. So that is called FEV1. So that is what you find in the report. FEV1, say 60%. And the diagnosis impression under that, then the report is obstructive lung disease. Okay. However, we can have another type of a situation which is like this. Here, the maximum amount of air that that person can breathe in is much less. But then the flow of the air is quite normal, so that since the amount of air had to be breathed out is less, almost all the 100% is breathed out within 1 second. So the FEV1 is even higher than normal because only a small amount of air had to be breathed in. FEV1 may be 100%, but the maximum amount of air that could breathe in, that is much less. So the vital capacity is very much reduced, but FEV1 is normal. Now this, as you can imagine, would happen when the chest cannot expand enough. So this is not obstructive, this is restrictive lung disease. So when there's a restriction in the expansion of the chest does not expand enough, the person will breathe in only a small amount of air at a time, but because there's no obstruction, he'll be able to breathe out at the normal rate. So the time to vital capacity will be still normal. Now we come to one more concept, and then that will be the end of today's session after this concept of dead space. Hmm. Now, dead space is the amount of air that fills the airways. And in this diagram, it has been crossed out like this, from here up to here, and also in the smaller airways, right up to that level where the gas exchange actually takes place. So right from the nose up to the entire bronchial tree, till we reach the level of alveoli or the air sacs where gas exchange takes place, all this is dead space. Why is it called dead space? Because this does not participate in gas exchange, but at the same time, effort is spent on sending in the air into this space and sending it out. Because air cannot reach here unless it passes through this, and the air cannot go out unless it passes through this. So every time we breathe in, this much we breathe in, uh, without its participating in gas exchange, whereas and same time when we breathe out this additional volume. In fact, this is the volume which goes out first before we start breathing out that air in which gas exchange has actually taken place. So this is the dead space, and that's why Anthony Smith has called the lungs the brilliant execution of a poor design. Why has he called it a poor design? He says that this is like a bus with a single door for entry and exit, huh? Not a double door bus where passengers get in from the back door and get down from the front door. It's not a double door bus. It's a brilliant execution of a poor design. Whether the design is poor, that one can argue, because one can think of all the difficulties that would have been having, that would have been there if it had been a double door bus with two exits. But all the same, is admitted it's a brilliant execution. Anthony Smith's books, book was one of those which used to collect dust in the library, and only some crazy people like me picked it up to read such funny things in it. That is where you read that if you spread out all the alveoli of the lungs, they'll occupy the same space as a tennis court, and the lungs are a brilliant execution of a poor design, like a single door bus. Anyway, that was just a digression. Probably that helps you in keeping the mood a little lighter and interlude between more serious stuff. So coming back to dead space. So dead space is this entire space in the airways and in this tree, bronchial tree, till you reach the level of the alveoli. Before that, it is all dead space because it does not participate in gas exchange. All the same, we have to move that amount of air with each breath. Otherwise, we can't breathe in and out. So this dead space is normally about 150 ml. And we saw that the tidal volume is about 500, which means that out of the 500 ml that we breathe in and out at rest, 150 uh, are taken up by the dead space, only 350 reach the gas exchange areas, and same when we breathe out, only 350 ml from the air that has gone through the gas exchange comes out. Before that, 150 ml comes out from the dead space. Now that leads to the concept of two types of ventilation: pulmonary ventilation and alveolar ventilation. That is the extent to which we ventilate the lungs, that is pulmonary ventilation, and the extent to which we ventilate the alveoli, the air sacs where gas exchange takes place, how much we ventilate the alveoli. And let's see how we get that. So the tidal volume, that is the amount of air that we breathe in and out with each breath, is half a liter, 500 ml, 500 milliliters or half a liter. The respiratory rate, let's assume, is 12 per minute. So the pulmonary ventilation will be 500 multiplied by 12, that is 6 liters per minute. The person is breathing in and out 6 liters of air per minute. But then dead space is 150 ml. So alveolar ventilation is this 500 minus 150, because this is not contributing to the gas exchange. So this is not a part of alveolar ventilation. Multiplied by 12, the respiratory rate, that gives us 4,200 milliliters per minute. So although the person is making the effort of moving 6 liters of, 6 liters of air, uh, the volume that is actually contributing to gas exchange is only 4.2 liters. Now, what is the practical implication of this? The practical implication is, which breathing is better, slow and deep or rapid and shallow? And let's see that, how it happens. Now, this is rapid and shallow breathing. You need not look at this side, just look at this side for a moment. Rapid and shallow breathing. The tidal volume is 300 ml. Shallow breathing, so it's less than 500, 300 ml. Respiratory rate, 20 per minute. Rapid breathing. Pulmonary ventilation, 6 liters per minute. Similar to what we saw in the previous one, 500 multiplied by 12 or 300 multiplied by 12D. So that was average breathing. This is rapid and shallow breathing, 6 liters per minute. Dead space, 150 ml. So alveolar ventilation, 300 minus 150 multiplied by 20, which gives us 3 liters per minute. So this person is actually getting useful ventilation, which will participate in gas exchange only to the tune of 3 liters per minute. Now let's see slow and deep breathing. The tidal volume is 600. The breathing is deep. So tidal volume is double. With each breath, the person is moving the double the amount of air, 600 as compared to 300. Respiratory rate 10, slow breathing. Not 20 per minute, 10 per minute. Pulmonary ventilation is still 6 liters per minute. 600 multiplied by 10, again 6 liters per minute. Dead space remains the same, 150 ml. So how much is the alveolar ventilation? 600 minus 150 multiplied by 10, which gives us 4.5 liters per minute. So for the same effort, for moving the same amount of air, this person is getting 1.5 times the beneficial ventilation or useful ventilation, which will actually participate in gas exchange. So instead of 3 liters, 4.5 liters, the effort involved in breathing is the same. So you can see which is more efficient. Slow and deep breathing is more efficient and better than rapid and shallow breathing. And that is what we teach in the yogic practices. We saw earlier why abdominal breathing is better than chest breathing. Try and inculcate the habit of abdominal breathing. Slow and deep breathing is better than rapid and shallow breathing. And that is what we do in yogic practices. Slow and deep breathing instead of rapid and shallow breathing. And you can see why. Okay. So which is better, slow and deep breathing or rapid and shallow breathing? Obviously, slow and deep breathing is much better. So the best way to breathe is abdominal breathing, not chest breathing, and slow and deep breathing. And that is what we do in yogic practices. So we might have been breathing for decades, but still need yoga to teach us how to breathe. That's the sad fact of life. किसी को कहें कि सांस लेना सिखाएंगे योग में, मैं तो 40 साल से सांस ले रहा हूँ. What will you teach me? But the fact is that we sometimes need yoga, and so many of us need yoga to teach us how to breathe. It also teaches us how to eat, how to sleep, things which we have been doing for decades. The same books have this also. The Human Machine, which is a popular book, and these two, which are textbooks. Fundamentals of Physiology, about 400 pages, and Understanding Medical Physiology, about 1,000 pages. And this is the book from where I got the pictures. It has Anatomy and Physiology, and it's an excellent book, about 1,000 pages again. This is a view of the ashram, the meditation hall and the shrine of Sri Aurobindo Ashram Delhi branch, the place where I stay and work. For any questions or comments besides what we may take up now, you are welcome to write us on yes@yesspirituality.com. My gratitude to the Mother and Sri Aurobindo for making these sessions possible, and thank you all for being there. Aditi, just
Yeah,
see
can
if
I
there are
ask the
questions.
question? Yes. Since diaphragmatic breathing is so critical to life breath in a sense, why is this not taught in school?
So many things which should be taught in school are not taught. That's why we keep complaining about the school education. Uh,
Yeah.
this is one of them. Why it is not done? Uh, that's because first time as a society we have to be conscious of it. Uh, Children learn what we think is important. That is what shapes the education in schools. We teach what the teachers themselves learned and the way they learned. That is what shapes education, not documents on education policy.
Yeah. Thank you.
Any more questions?
Yeah, I had a question. Why is it when smaller kids fast?
That's a good question. Why small kids have a tendency to breathe fast? Because in relation to their body mass, their oxygen requirements are higher. And to meet that, they need to breathe faster and deeper, just as they need to eat more food. Because in relation to their body weight, their energy requirements are much more for two reasons. Firstly, they are growing, so they need energy also for adding new living matter to the body. And secondly, in general, they are physically much more active. Look at a 2 or 3 year old child, can't sit still for a moment. And therefore, anyone who's taking care of that child gets tired. The caretaker gets tired, but the child doesn't.
True. Now I had
I
one
mean,
other
we digress
question.
a bit. It has also been seen that one of the signs of marginal malnutrition in children is that they become physically less active. Then they don't spend that much time running around, which means the first casualty of marginal malnutrition is less physical activity. So the body has that regulatory mechanism, but it's not the desirable thing to happen. And before anything more serious happens, the child just becomes physically less active.
Thank you. Interesting correlation with physical activity and malnutrition. I had one other question. When we go to a doctor and he examines your lungs with a stethoscope, um, he would ask to breathe in a certain way when he's examining the front part and the back. Why is that? Can you please explain that?
Yes, the doctor asks you to breathe with the mouth open. Now,
Mm.
not the ideal way, which is nose breathing, because then that gives the doctor an unadulterated view, or rather sound, of what is happening in the lungs. Because the doctor wants to happen what is happening to the airflow in the lungs, not what is happening in the nose and the throat. And to reduce the intervention of the nose, it tells the patient to breathe through the mouth. So for that minute or two which the examination is going on, it is okay. And what is the doctor trying to hear? Normally, what the doctor can hear is inspiratory and expiratory sounds. Both during inspiration and expiration, there is a sound, and the expiration should last at least longer than inspiration. But the abnormal sounds are either because of congestion in the chest, which means if there's an infection, there will be some fluid accumulation, which we call congestion. That gives rise to one type of sounds, which we call crepitations. It's like a crackling sound. And the second type of abnormal sound, major type of abnormal sound, is what we call rhonchi, which is whistling sounds. These whistling sounds or rhonchi are because of airway obstruction, because when the air passes through narrow passages, it makes sound, and these sounds are uh, more during breathing out than breathing in, because during breathing out the resistance is greater than while breathing in. That happens because while breathing out the pressure in the chest is positive. We just talked about breathing in, that the pressure falls, so the air rushes in. The opposite happens when we breathe out. The pressure increases, so the air rushes out during breathing out. So when the pressure increases so that we can breathe out, this higher pressure also squeezes the airways. And if there's already an obstruction, and on further there is further squeezing because of the higher pressure while breathing out, these whistling sounds increase. So these are the two major types of sounds that the doctor is looking for in the chest.
Thank you so much.
Any questions in the chat?
Yes, there's just one question just came. I'll just read out. This question is outside the lecture. Refined cooking oils have a lot of chemicals, so we are told cold compressed oils are better. But is it safe for high temperature cooking?
Well, I mean, finer distinctions between different types of oils, Ayurveda people are more experts at. But there are a few sort of things which perhaps one could say. One is that certain oils are not suitable for high temperature cooking, like olive oil. That certainly is not. And some oils are very well suited for it, particularly ghee. Comparing refined and unrefined, yes, it's quite possible that refined oils are more suitable. But then unrefined oils can have some additional merits, which are particularly sort of uh, told by the Ayurvedic physicians. One of the things which in modern scientific nutrition also we know is that the other components which are there in the unrefined oil, the uh, could have some nutritional value, particularly say if you take refined and unrefined palm oil. The unrefined palm oil is reddish in color, and that is because of carotene, which can be which is a precursor of vitamin A. So some of these things are lost in the process of refining. But we do not know as much of this because we may not know everything that can be talked about in terms of the chemical changes and so on. But the Ayurvedic physicians don't even look at that. They look at the overall effect, which is based on the basic textbooks, which has been confirmed in their experience through thousands of years. So that is what they basically talk about. But then they do have a lot more to say in favor of unrefined oils as compared to refined oils.
Thank you.
Sorry, can I ask one other question? I had I mean, I would like to know about how hiccups and yawning has got to do with our respiratory system. If it's a topic for another discussion, that's totally fine.
Well, these are two aspects of physiology about which we do not know enough, although we do know something. But then they're not taken in much in detail because they don't seem to have important implications in health and disease, by and large. Hiccups are jerky movements of the diaphragm. Why they happen and how, what brings them on, what makes them suddenly disappear is not really understood. Yawning is considered sometimes a sign of sleepiness, sometimes a sign of boredom. It could be both, but again, why it happens, how it happens, and it also infectious. That is another important thing, which means if one person is yawning, the next person starts yawning. All these things and observations are there, but it's poorly understood. And another interesting observation on this is that among other species, probably besides human beings, it's only monkeys that yawn. Shows that we have some relationship with the monkeys.
Thank you. Because as per Ayurveda, they say hiccups is, I mean, they categorize hiccups as a disease. That's why I was curious to understand what does modern medicine say about hiccups.
We don't know enough really, as I said, but certainly, very rarely though, hiccups can become a very troublesome feature.
Okay.
They can become quite troublesome to a person when they just refuse to stop. But usually they are only for a short while and they stop on their own.
Okay. Thank you so much.
Sometimes perhaps to divert the attention of the person who is having these hiccups, all types of explanations and stories are told. The way in my childhood, my mother would say that if you start having those hiccups, your uncle is remembering you. So that diverts the attention of the child perhaps, and your hiccups stop. If you pay more attention, then these things have hiccups have a tendency to continue.
Thank you.
So you start talking about the uncle rather than about the hiccups.
Next question.
Maybe as a curious child, you start asking, how does the uncle's remembering travel such a long distance and affect my body? But for that, we do have explanations now in spirituality. The mind of a person at a long distance can affect our bodies here. I think there was some question.
Yes, there's a question in the chat box. Why asthmatic patients struggle more to breathe, especially when they're having some attack, and how they can take care of their breathing?
Yes, attack means that they have difficulty in breathing, and the person may have the tendency to bronchial asthma all the time. The attack is brought on generally by a combination of factors. Uh, some of them are an infection of the respiratory tract, uh, extremely cold temperature, mental stress, and sometimes heavy exercise. These are some of the precipitating factors which can bring on an attack in a person who's otherwise prone. So they are more likely to occur in winters than in summers, and more likely when the person is under stress. And of course, cold exposure and heavy exercise should be avoided. Uh, these are some of the things which can precipitate the attack. How to deal with it? Probably the safest in an emergency is to go to the hospital where they would give you an injection within less than a minute, intravenous aminophylline, and the person is relieved. But if that is not accessible, then Swami Vivekananda Yoga Kendra at Bangalore, they have come up with a technique which they call chair breathing. And we'll not go into the details of it. Basically, you sort of you sit on the floor, hugging the back of a chair, and then you go through a series of slow breathing and chanting practices. Chanting means humming practices, where you synchronize the breath with a hum like Om or Om. So they have made it a sort of a technique with clear-cut steps. First this, second this, third this. But the basic principle is that. And they say that almost 100% sure that even an acute bronchial asthmatic attack gets controlled just by doing that. And how did they learn about it? That they say they learned from a patient, a poor patient who did not have any means of rushing immediately to the emergency services in a hospital. So they asked him that when he came to the Vivekanand Kendra for treatment, they asked him that, what do you normally do? You have been, for years, you have had this problem. What have you been doing? He said, क्या करें जी, चारपाई पकड़ के अम्मा अम्मा करते हैं. And we just hold the cot and remember our mother, amma karte hain. And that seemed to help. So then they thought, can this itself help? And then they elaborated on it and sort of came up with a technique which they call chair breathing.
What can be done? What can one do to avoid sneezing attacks?
Yes, again, I mean, good question. It's basically smelling something unpleasant, which gives the sneezing reflex, just as getting something unpleasant in the throat gives the cough reflex. Having said that, uh, one of the ways to stop a sneeze is to place the finger just under the nose. Most of the time, the sneeze goes away. One doesn't continue to sneeze. But then sometimes they may not. And that may be because of an acute allergic attack when I suddenly breathe some pollen grains or something. And the result is these sneezes, one after another. The nose starts running, the eyes may start watering. But this type of acute asthmatic attacks generally go away as suddenly as they came. No treatment seems to be required. So these are some of the things associated with sneezing.
Thank you.
There are no more questions in the chat box.
Now, can we thank you for really such an excellent lecture series? Your explanation of what happens and what you can do when you're flying to reduce the pain in the ear and prevent a problem in the ear is just such a simple explanation and very, very useful. Thank you.
Thank you so much. And don't thank me. Thank the mother from whom all this comes, and the type of conditions and circumstances I got in life, which makes it possible to say something useful. Even today, having been out of the environment of the All India Institute of Medical Sciences for almost 20 years, still I can communicate something useful. That's the Mother's grace.
Thank you to the divine.
Thank you.
All right,
Okay,
I think,
Aditi? I can
yes,
wind it up.
since there are no more questions, we can end today's session with a moment of silence, and tomorrow we continue with the same respiratory system. Thank you, everyone.